Thank you very much. Thank you very much. It is my pleasure to be here this afternoon, and I really would like to thank Professor Michael Moore, Dr. Marta Romazzi, and the World Federation of Public Health Association for having organized this webinar on such a crucial topic. I know we are in the area of digital events. I just thought of bring a little bit of context. This is the University of Pavia, where I'm talking to you from. And I'm glad to mention that I'm talking from the University of Pavia, which was funded in 1361, is one of the oldest university in the world. But the reason why I'm telling you that I'm talking from here is that because from Pavia, in Pavia, we had as public health professor many years ago, John Peter Frank, which some of you might know is considered one of the first public health physician who wrote a comprehensive 9-volume treatise on all aspects of hygiene and public health. I just wanted to give you a hint of where I am. My tasks, I know we are a bit short on time, is to bring the perspective of healthcare workers. We know a lot about vaccines uptake determinants. I'm glad that one of our keynotes today was my great friend Julie Lees, who have researched a lot on the determinants of vaccine uptake. So it is not important to remember, given that we are within public health experts, that if we talk about vaccination, we're not talking about vaccines. We know that vaccination means much more than having the availability of vaccines, and we do know that the determinants of vaccine uptake relies on both demand side determinants and supply side determinants. And we have, especially in Italy, but also in Europe and across the world, researched a lot in recent times on determinants of vaccine uptake, more specifically on the demand side. And I'm glad that Julie mentioned something, her research about vaccine hesitancy. So why are we talking about this in the COVID-19 area? Because there are many things that are new. We all know that we are fighting a new pandemic infection in a new area. We can call it the digital area, but this is an important aspect to bring to the discussion while discussing the perspective of specifically healthcare workers in the middle, at the start, I would say, of the COVID-19 immunization campaign. So first of all, two elements. It is a new pathogen, we know that. It is a new and very dangerous disease, counting today almost 2.5 million deaths across the globe. And we're also talking about new vaccines. And those are all elements that have to be taken into account. And I do hope that we can discuss more those issues in the panels that will follow. So number one, we are facing something new with reference to the pathogen, the disease, and the vaccines that we are starting to have available. Number two, we are in a new area. We've been researching on previous pandemics, but in this, we can call it digital era. I'm very strict on definitions, but this brings some elements, some new elements, both on the demand side, meaning that the means of communication, the tools that we have to communicate and interact are somehow new for the first time in a pandemic area, and also the instruments that we do have to build on health education and health communication. But also on the supply side, we have new tools to organize and manage preventive services delivery, which can be used to make the campaigns more efficient, more rapid, and to better collect research and practice data. Why do we talk about healthcare workers? Well, for multiple reasons, and I'm just wanting to list them so that we can maybe expand on some of the points later. we know that healthcare workers, and it is a category that I belong to, as many of you, have been prioritized at the start of the global mass vaccination campaign for obvious reasons. The WHO, together with other national health authorities, have issued documents identifying which are the elements to allocate the vaccines, and most of the countries have started with the healthcare workers because we are at higher risk of exposure, because vaccinating healthcare workers protects and sustain health services for ethical reasons, and also because healthcare workers do work in settings where there are vulnerable populations. So there is the individual protective approach, but also the protective approach in healthcare services. So this is very, very, very known. And if we look at the map of Europe and of the globe, we know we are now at the stage of vaccinating healthcare workers, although at different pace and with different performances across the countries. But having this target population in mind, there are several considerations that we might do on the demand side, but also on the supply side. And I can already conclude, but I'm not finishing the presentations, that we are on an easy slope with reference to having to vaccinate the whole population. On the demand side, because there is a different risk perception, and we do know that risk perception is one of the elements influencing on the willingness to get vaccinated, balancing the protective effect of the vaccines and the side effects against the risks of getting infected and getting diseased. And we do expect, and we do know, that healthcare workers have higher knowledge, higher literacy, and the preliminary data that we do have available confirm this. So on the demand side, we have some specific elements if we're looking at healthcare workers. Preliminary data, I would say that we do have now available preliminary data on vaccines, attitudes, and awareness, hesitancy across the world. And those data are mostly preliminary, comes from different research designs, but those data are confirming that there is a degree of vaccine hesitancy within healthcare workers, physicians, nurses. We do have data from France, Belgium, and Canada. We do have data from Europe. We do have data from the United States. And so those data are somehow changing over time because the spread of the epidemic and the attitudes of the population towards the vaccines, while we were waiting for the vaccines, now that the vaccines are becoming to be available, so those data on hesitancy and attitudes are somehow changing over time. But also on the supply side, there are some specific issues. First of all, so by the supply side, I mean the organization and the offering of preventive immunization services. There are few. I mean, we are talking about a small target population as compared to what we have planned in the months to come, which is the whole populations. Administration of vaccines happens in hospitals, and so somehow the delivery of immunization services is relatively easy as compared to what we need to do from now on. And overall, the data that we have at the global, European, but also I can talk about Italian level, are promising, are telling that the acceptance, but also measuring and quantifying adherence rate, we're doing very, very well. The Italian case, just to mention, we have started vaccinating healthcare workers at the end of 2020 on the 31st of December. Our strategic plan issued by the Ministry of Health declared that health and social workers were to be prioritized. Of course, we have now vaccinated almost 3 We have administered 3 million doses for a total of 1,200,000, almost 300 healthcare workers. And those are the distributions by age, by type of vaccines, and by target population. As I was mentioning, the available evidence is, in my opinion, still accumulating, relatively scant and of poor quality, as I was mentioning, is changing over time. We need to differentiate, I'm sorry, we do not have time now to differentiate between attitudes measures versus adherence, and so to differentiate between demand and supply determinants of vaccine uptake. But overall, we do have very high adherence to COVID-19 immunizations in healthcare workers, although with some degrees of differences between different categories of healthcare workers, ranging from highest adherence in physicians, nurses, and lower adherence in other types of healthcare workers. Overall, this is empirical data from the hospitals that we are in contact with in the north of Italy. Overall adherence of 75%, which increases to over 95% if we only include physicians and nurses. We do not need to, we need to remember that physicians are important and healthcare workers in general, also because they are one of the highest sources of information, and we can consider them role models for the whole population. So it is really important from a health system perspective, but also from the perspectives of the image and the examples that they do provide to the general population. And the public reactions and concerns to the hesitancies of healthcare workers can indeed have negative consequences. So to maybe provide some discussion points for what we will discuss in a couple of minutes, we can say that we repeat, this is something that we all know. We are in a new era, but this has to be taken into account when discussing how to influence the willingness to get vaccinated and how to provide good vaccination services. Healthcare workers are key target populations for different reasons, from the individual protection perspective, but also from the collective protection in healthcare settings, and also for the sustainability of our health systems. There are specific features on both on the demand and supply side as compared to other risk groups and to the general population, for sure. They are role models, so we have to behave correctly. Preliminary data that we are analyzing shows that we're doing overall well on both the demand and supply side, but should I say that it has been easy, and the challenges with the general population immunization campaigns are really yet to come, because we will have different volumes and also very different target populations. So it's really the time to join efforts to get there, to reach herd immunity, starting from us, the public health community, and the community of healthcare workers. Thank you very much, in particular to my collaborators and to you all for the attention.